inviting Melissa. Melissa is the associate medical director. It worked. It's like a miracle in our times.
Hello.
Hi, Melissa. I'm so happy to see you. You know, it's like funny. I see Melissa all the time, except now with coronavirus world, we don't. I love that piece of art behind you, Melissa.
Oh, my mom made that.
That's amazing. That is amazing. It's so great to see you. And I'm laughing because I'm sitting here, I'm looking at myself with all my white hair. We were just having a conversation about our hair.
Yes.
So
it's all coming in.
Oh, you're still super dark. Anyway, This is Melissa. First of all, thanks everybody for joining us. This is Melissa. Everybody wave hi to Melissa. Melissa is the associate medical director, and I call her the vagina whisperer because she's the vagina whisperer. She's amazing. So, and we're here to talk about different birth control options and the problems that come up with them. We're getting a lot of hearts for you, Melissa. There are a lot of people who love you watching.
Oh, that's nice.
Watching this right now. Anyway, so the thing about birth control, like Melissa and I were talking about this earlier, is that like many gynecologists or Planned Parenthood can probably do a better job telling you about different birth control methods, but we deal with all the problems that arise because of the birth control. So we're here to kind of talk you through kind of the pros and cons of the birth control. And Melissa was saying, you know, but we see such a skewed sample because we see all the people that are having problems. But I do think that we also know the plus sides of birth control as well, right, Melissa? I mean,
of course,
as
right.
People who, and Melissa used to work in Planned Parenthood. So, but Melissa's the associate medical director. So you may see her if you ever come into Maze. She's awesome. And so I guess we can just start by talking about sort of the different kinds of birth control, and maybe we'd start with the ones that are kind of the easiest to put aside, because it's going to break into a couple of categories, like condoms. I'm thinking it's going to break into like condoms and spermicide, sort of the least complicated, have their own issues. The IUDs, all the various IUDs, which we got a lot of questions about. And then hormonal birth control, which would be the pill, the NuvaRing. Did I miss anything else in hormonal birth control?
Oh, there's the Nexplanon, that's the implant, and there's Depo-Provera, which is the injection, and then there's a new ring called Anovera. That's a 1-year ring. So there are a bunch of other hormonal birth control options that are not birth control pills that are out there on the market.
Okay, so maybe let's start with condoms and spermicide, because you want to just describe quickly how they're used, and then we can talk about what people say to us about them, what they like about them, what they don't like about them.
All right, so condoms and spermicides are both birth control options that are as needed. So you typically only use them when you're going to have intercourse and want to prevent a pregnancy. So the beauty of them is that you're not putting any hormones in your body. You only are using them when you want to use them. So you'll still get all your normal hormonal fluctuations and ovulate regularly, but you know, that's why we tend to like to recommend condoms, because they're, you know, not messing with your hormones. But condoms do have a good percentage of effectiveness, but they do need to be used perfectly in order to have a really high percentage rate. And condoms do break sometimes, or if you don't put a condom on properly, then they won't work. Or if you start having intercourse and then put a condom on midway through intercourse, they may not work because you've already had the penis in the vagina. And spermicides alone also, they're only about 70 to 80% effective if you're only using spermicide. And a spermicide is basically a chemical that kills sperm that you place inside your vagina, so that when your partner ejaculates inside your vagina, the sperm is killed. So, you know, that's also, you know, doesn't always work because there's millions of sperm and you have to kill them all. Right.
So the funny thing is that I always laugh when people talk about the effectiveness of, well, it used to be the diaphragm, which we're not even going to talk about anymore, I think. But like when you talk about like the effectiveness of condoms, because what they have to throw into that number is the number of people who say, I use condoms, but then actually don't put a condom on that time that they had sex, right?
Right,
so
exactly.
So people should just be aware, when you're looking at statistics, they're trying to look at statistics of, you know, somebody who uses condoms or somebody who or use this spermicide, but then, oops, you know, 2 out of 10 times they don't.
Right.
So that skews the number. So people should know that.
Condom, right. Perfect use of a condom is used every time put on prior to the penis going inside the vagina, and then, removed after ejaculation and thrown out.
So using it every time it's a pain in the neck. But the other thing, sometimes people complain that it doesn't feel as good either for the man or for the woman. I do think there are some more expensive condoms, like lambskin condoms that people say feel better, right? So
yeah, lambskin condoms tend to be a little thinner, and for patients who have latex allergies can be really helpful. However, lambskin condoms will not prevent sexually transmitted infections. So only the latex or the polyurethane nitrile type condoms will do that. So if you're in a monogamous relationship and you're not concerned about sexually transmitted infections, then a lambskin condom may be a good option for you, because their effectiveness is very similar to other types of condoms, but they do not prevent the spread of HIV. So, you wouldn't want to use them if you're potentially having multiple partners and their status is unknown.
So the only thing I want to throw in about condoms and condoms, not necessarily spermicide, for any Orthodox Jewish people who may be watching, because I get these questions a lot. I cannot go into the Jewish law piece of spermicide. I don't know if Catholics have the same issue. Well, Catholics don't like birth control in general, I think, right? Anyway, so with this, I had to do a whole other podcast called The Joy of Text that deals with all the Jewish law stuff. So if you're interested in condoms and Jewish law, which a couple people have texted me, go there, because we're not going to discuss that. So I think we will just move on to IUDs, our favorite method of birth control, right?
Yes.
Yes.
So I do love IUDs. I love IUDs because they are, long acting. So once they're, they are multiple different types out there, but the one that has the lowest time period is 3 years. And then the Mirena is 5 years. Some can even say they can leave it in for 7. And then there's the Paragard IUD, which is the copper IUD, and that is good up to 10 to 12 years, depending who you ask. And there are a couple other, the Liletta is also very similar to Mirena. It's just another brand that's also 5 years too. And then the Kylena, that's also another 5-year.
Crazy. They're coming up with all these cute little names for them, right?
Yes.
I'm waiting for one Melissa. I don't think they're going to name it Bachava, but I do think they're name one Melissa. So here's the story, because I think people get really confused about the hormone situation. So the copper IUD has no hormones in it at all. The other ones, and maybe I don't know if you tell it, have some hormones. What people don't understand is that they have this tiny amount of hormones that are just meant to work inside the uterus, and it's not the hormones that go through your whole system and regulate your system the same way like birth control pills do, right?
Right. So the copper IUD has no hormones in it at all, and it works by the copper in the IUD actually prevents the sperm from swimming. Prevents the sperm from swimming. It creates an environment where they can't reach the egg. It can thicken cervical mucus because there's something in there, and so the egg and the sperm can't meet. So if the egg and the sperm can't meet, then you can't have fertilization. But the downside to the copper IUD for many women is that it does create much heavier periods. So typically I'll tell women, if your period was like 5 days, you're probably looking at a 7 to 9 day period with the copper IUD. You could be crampier. You could maybe pass more clots, just because this copper IUD is creating an environment in the uterus where the lining of the uterus gets thicker. It's basically a foreign object. So your body initially is not really sure what to do with it. So the lining gets a lot thicker. So when you do have a period, you get a much heavier period. As the months and years go on, you tend to get used to it. And so that gets a little bit better. But usually, no matter what, with a Paragard IUD, your periods will be heavier. So
one question I did get from somebody was, which I think the answer is there isn't, was I'm on the Paragard IUD. Is there anything else I can do to make my periods be less heavy?
So, I mean, you could go on the pill, which would thin the uterus, but that's sort of overkill at that point. I mean, when you actually get your period, sometimes taking ibuprofen kind of prophylactically right before the period and throughout the period can help with cramping and maybe a little bit, but typically, unless you're going to take, something on top, some sort of hormonal something to thin the lining on top of already having the Paragard, there's not much to do.
Right. Which is
Yeah.
why so many of our patients prefer like the Mirena or the Skyla.
Right.
Or the
right.
Liletta, or the I'm just making up names now.
Yes.
Yes. And the
Mirena, Liletta, Kylena, and Skyla. Those are the progesterone containing IUDs on the market. They basically were created, I think, partially because women complained about the heavy bleeding with the Paragard. And so they said, well, if we put some localized progesterone in these IUDs, it would help thin the lining of the uterus so they won't bleed as heavy. The Liletta and the Mirena have the highest amount of progesterone in them. So with those, you're probably more likely to have less bleeding than with the other two IUDs, which have much lower doses of progesterone in them. Some women these progesterone containing IUDs are not meant to suppress ovulation. The progesterone in it is not meant to systemically suppress ovulation. But sometimes it does happen, but that's not really how they're meant to work. So I will talk to women who will say, I don't regularly get periods, but I do know I feel like I'm ovulating even though I don't get a period. And they're not getting a period because the progesterone is thinning the lining of the uterus so that when it's meant to shed, there's really not much there to shed. So for the higher progesterone IUDs like the Liletta and the Mirena, I think they say at anywhere between 6 months to 12 months, most women have amenorrhea, which means they get no periods at all, or even very light staining or spotting. And sometimes with the lower dose.
Really love, right?
Right.
A lot of women love that they don't get the period, and it doesn't. The reason I started out by saying we love it is because usually, again, everybody's so different. We try to respect everybody's experience. We usually don't see a huge drop in sex drive from right.
And you might, I mean, some women do say when they first get one of those progesterone IUDs inserted, they may feel some sort of hormonal surge because it's first going in and sort of the first uptake of the hormone into the body, but it usually regulates out. If anyone is going to get an IUD, I usually recommend them sticking it out for at least 3 months. And that's probably with any form of birth control. I'll tell patients, like the pill, the NuvaRing, anything. I'll say, you really got to give your body 3 months to get used to it. And then after the 3 months, if you're still miserable, then it's worth looking into a switch. If you are going to get an IUD inserted, the experience is not the most pleasant. So I think most women would want to try to keep it in for a significant period of time, but you can have an IUD removed at any time. So if you have an IUD put in and you are miserable after 2 months and you hate it, you can have it, just pull it out.
One of the people watching said I gave it way more than 3 months. And I'm just asking that person who I know actually, hi Sarah, that that did it get better after that? Because usually it does take a while till you stop spotting. But
especially with the IUD.
Months, it's 3 to 6 months. So
I mean, it depends on the side effect. I mean, if it's a bleeding side effect, as long as it's not super heavy bleeding, if it's breakthrough bleeding, lots of brown staining, those sort of things, then I would say you got to just wait it out. If you want to keep it in.
She's saying it's 8 months, which I do hear. The other thing that I've been hearing and seeing, and so I don't have data on this at all, so don't quote me on this, but I feel like the younger women, when they get it in, the women in their 30s, somehow their period sort of slows and stops faster than the women who are like perimenopausal. Menopausal, somehow it takes much longer. So just and some people
everybody's different. I think it also depends potentially on how heavy someone's periods were to begin with. If you're someone who naturally maybe had really light periods, it may be easier. If you're someone who had lots of crampy, heavy, clotting type periods, it may take longer.
So now I think we need to go. So the reason we love the IUD is because it doesn't mess with your systemic hormones. It really is a local hormone for the most part. And so whereas now I think we're going to shift to the sort of classic birth controls, which is what most people are struggling with. which is the hormonal birth control. And as you said, Melissa, there's a gazillion kinds out there, but I think most people are on the pill. Is that a fair? I think that's my experience.
I think the birth control pill is by far probably the most common birth control option out there. It's the easiest to get. It's probably the cheapest. If you get a generic pill, easiest to control, start and stop.
I'm going to stop it just for, I'm curious from all the people watching, how many of you are on a hormonal birth control now? Just like send up, I don't know, send up thumbs ups or something so we can see. Because I think that really by far, somebody just said that it took, that she also had the experience that younger women do better on the IUD. So coming back. But anyway, yeah, so let's go back to the hormonal birth controls. Yeah.
Right. So so I think the birth control pill is the easiest. There are so many different brands out there. So there are lots of generics for different pills that used to be really common. Like, everyone back in the day was on orthotricycline low. Now that's generic. So what birth control pills do is they prevent pregnancy by giving you this low, steady state of hormones, which suppress your ovulation. So you suppress this hormone called FSH, which stimulates the follicles to release an egg. So you suppress that. So by suppressing that hormone, you don't ovulate. And if you don't ovulate and you don't release an egg, you can't get pregnant. But with birth control pills, you do need to take them every day. The combined pills, they're the ones that have estrogen and progesterone in them. They tend to be the ones that are most commonly prescribed. You need to take one every day, and typically you can get a period every month regularly on time by following the pack of pills. And the other birth control pills out there are progesterone only birth control pills, which are a little different in that they only have progesterone in them. So you do need to take them every single day, and you have to take them exactly at the same time every day because they're a little less effective.
So the reason let's talk about why we don't love birth. I mean, we love birth control pills because they're easy for people to use and people usually stick with them. And that part is the great part, and they prevent pregnancy. And so they're super convenient, but we also don't really like birth control pills often. Now, here's where we do see the issue because, well, why don't you talk about it? So,
Right. So the side effect at our practice, the side effects we see from the birth control pill or any hormonal type of birth control that suppresses ovarian function, like the NuvaRing and the Nexplanon, is by suppressing your regular ovarian function, you're not getting your own natural fluctuations of estrogen and also testosterone. Those are two really important hormones for women in order to
carefully, because it's not just estrogen. Women think of estrogen as being the only hormone, but testosterone is super important too, and that also gets suppressed by
and that's often why women on birth control pills tend to have less acne, because we're also suppressing testosterone. So those two hormones are suppressed because your ovaries they're basically in like a sleep mode and they're not ovulating, so you're not getting these good fluctuations of your hormones. And as those hormones stay low, that can translate into dropping on libido. And the one that I think I see even the most is that it can affect the vaginal tissue and the vaginal entrance, because the vagina really needs estrogen and testosterone to thrive. And for women who are on birth control pills for a long period of time, and typically this is a cumulative effect as those hormones are continually suppressed and the vaginal tissue and the vaginal entrance is not exposed to those fluctuations of hormones, it can become more dry, more irritated, more sensitive. And then that's why we often see women with this hormonal related vaginal penetration type pain, because that tissue is just not as healthy anymore from being on the pill for a while.
And what's interesting is, and it drives us a little bit crazy, Melissa, is that we sometimes have women come in who have started having pain with intercourse, and like we say, oh my God, the tissue on your vagina is kind of a mess. And then, we think you need to get off the birth control, and they say something like, oh my God, I thought it might be my birth control, but my doctor said it couldn't be. And that makes us crazy. And I also want to say, somebody wrote in that they think is NuvaRing you know, better because they think women tolerate it better, but our experience is not. The NuvaRing has the same experience, right?
Yeah, in theory, it would do the same thing. I mean, everybody is different. I mean, possibly because the NuvaRing is going in the vagina and there is localized action, maybe it may be a little better. I think that we tend to see more women on the pill have the vaginal complaints, but I do think the NuvaRing has the same action on the ovaries, so it would translate to the same issues.
So what are women supposed to get? This is the question. Like a woman comes into us, and so I think this is where everybody's going. Like she comes in and she says, I hate my, let's say, hormonal birth control, right? Like I'm on it. It's making me super moody. It's making me depressed, or it's making my vagina a mess, or it's making my libido. I don't even know where my libido went. So we're a little bit stuck when we go there. So like, so let's talk about what we tell those women.
Yeah, I mean, I think that we always have to weigh the pros and cons, right? So if a patient is willing to get an IUD, I think that's always the best switch if they can do it, because we do have the best experience with that as far as sexual functioning goes. And if they are not willing to do that, then my next option, I usually do encourage, if they can use condoms, to, you know, do use condoms. Condoms work really well if you use them. I mean, that's the thing. You need to have someone who's committed and a partner who's committed to use condoms.
Wait, I want to jump in because somebody wrote saying that her gynecologist told her that younger women aren't affected. Their libido is not affected by hormonal birth control or the pill. And is that correct? And that is absolutely incorrect. Now, I want to say one more thing, which Melissa and I are always talking about. This is so individual. Like you shouldn't assume, you shouldn't come off this conversation saying, I can't use hormonal birth control because it's going to affect my vagina or it's going to make me have no sex drive, because it is so freaking individual. Like we have women who are on it and are fine.
Right. And there are millions of women on birth control pills who would say my libido is fine and my vagina is fine. I think it's just important to know that this potentially could happen. I think there are lots of different pills out there. So what I seem to find is that the low dose birth control pills, which are the newer generation of birth control pills, tend to sometimes be worse than the older generation of pills. So if you are
Even though they're lower dose estrogen.
Right. Yes.
And do we have any idea? Why that is?
So the newer generation of pills, you know, they are tweaking the progesterones in them. They are putting much lower doses of estrogen in them, and they are trying to oftentimes make them more anti-androgenic, because that is what causes the acne and the weight gain and things like that. So these newer generation of pills, as opposed to the older generation of pills, which was really more just trying to prevent you from getting pregnant, and they had much higher doses of hormones in them, sometimes work a little bit better. So your first option,
better, meaning the vagina is not as bad,
right, or you may not, so potentially your first option is to maybe say, let me try a different pill first, right? If you really don't want to switch pills, maybe try a different brand and see if that makes a difference. I think some women feel better on one pill over another, and it can take maybe a couple tries to see which one you like best. That's always an option. And then, you know, the IUD, condoms, you know, if you really can't come off the pill for some reason, then we have to do some sort of workaround. I mean, that's sort of, you know, we have to respect everybody, and pregnancy prevention is really important, especially in our young patients, when they really don't want to get pregnant. So we need to, you know, try to work around it.
So sometimes when the vagina is kind of a mess, because we see a lot of pelvic pain, and so people come in, we'll just give you extra estrogen and testosterone creams to make up for what that birth control pill is taking off of you, which works pretty well. It's the libido piece that we really struggle with. We don't really have a good option for that, right? I mean,
right.
And we can't really
Yeah.
do anything. I'm trying to think of, do we ever give people a testosterone? I don't think we
Yeah,
do.
I think I've given DHEA sometimes with someone on the pill to see if that might help. You could always treat on top of the pill and see if that makes a difference. But again, you're kind of giving something to counteract something else. So,
Not a great
not
first option, right?
right.
Um,
Yeah.
Somebody just wrote in that diaphragms are making a big comeback. She
Hmm.
said overseas,
Yeah.
which is so funny because I mean, I have to say, like, as the generation of diaphragm people, they were
Hmm.
like such a pain in the neck. I mean, women would just talk. You
Right.
could just endless jokes about the diaphragm. They are natural. The ones
Right.
that you're putting in the cups, you know, the menstrual cups, like
Hmm.
putting in
I
a
mean,
diaphragm.
right. Yeah. And I
Yeah.
mean, I know diaphragm users, some women who really love diaphragm, you can leave them in for quite a while. So if you're worried about spontaneity, things like that, um, some women would just kind of regularly put them in, no, like every Friday and Saturday or something. And if they knew that it was going to happen, especially if you're someone who, schedules their intimacy in, a diaphragm could be really easy to just, put in, and they have to stay in for a certain amount of time after, but you can put them in earlier too. So they just do work best when you're using a spermicide with them, because you need to put the spermicidal gel around the diaphragm. You have to use them together.
It will be really, really ironic if the diaphragms make a comeback. I just think that's hysterical. We shifted away and it will just be, which I get it. Like, we're all realizing how not great these hormones are for us. But I think it will be really funny if that happens.
Yeah, I mean, if you use a method like a spermicide or a diaphragm in conjunction with some sort of natural family planning, which would be sort of avoiding
Somebody
ovulation
did
time,
ask us if we could talk about
then
natural options. So can you just spend
yeah.
another minute talking about that?
So, right. So you can predict ovulation in some ways. I mean, the easiest way is sort of a guess by looking at your calendar, right? If you are someone who's quite regular with their cycle, you can sort of predict when ovulation would happen. I mean, if you have a 28-day cycle, we usually say it's around day 14. So if you just avoid those time periods, then you're less likely to get pregnant. But you could take body temperature. That would the body temperature rises when you ovulate, but you'd need to actually take your temperature every single day in order to see that change. And checking
Which may not
cervical
be a bad
mucus
idea.
too.
It may not be a bad idea now with COVID-19 stuff. Like, I feel
Right.
like we should take our temperature anyways.
True. And also, like, cervical mucus changes when you are ovulating. So sort of looking at that too is just another indicator. But if say you were someone who really didn't want to use condoms, but didn't want to use anything hormonal and wanted to use spermicide is about 75% effective. If you kind of combine that with natural family planning and really avoiding ovulation time, that
You're getting it up
would
to
make
about
it
8 to
more
9.
effective.
Yes.
That would make it more effective and might be worth it. I would probably, maybe not suggest that to someone who is like, I definitely do not want to get pregnant.
Right. I will
But
kill myself if I get pregnant.
right, then I would probably say you want
right.
something stronger. But I think we sometimes have a lot of patients who are like, I'm really not ready for a child now, but like, if it was to happen, like whatever, we would have the baby. But we're thinking next year. So in that case, if they
85 to 90%.
85 to 90% might be fine for them. Right.
So
Right.
the other thing about the pill, just spend a minute, maybe if you don't mind, is that when you take the pills, you can use them all continuously and only get your period
Right.
every 3 months or so, right?
Right.
And that,
Right.
I don't think people realize that. I think people think they have to take a specific pill for that reason, but
Right.
not true.
Not true. Right. Any combined oral contraceptive, meaning a combined pill that has estrogen and progesterone in it, can be used continuously, meaning that you can take active pills every day. And that would, as long as you're taking the active pills, you typically would not get a period. So you could take the active pills for, 11 straight weeks and then take a week off and get a period, or 7 weeks and then get a period on the 8th week. So you can do that with any type of pill, although usually the monophasic pills, which are the pills that are the exact same dosage of hormone in every pill every day, tend to work best than the ones that are phasic, meaning that one week there's a different dose than the next week. So like orthotricycline is triphasic, meaning every week the hormones adjust. Whereas orthocycline is the same every single day. So you'd more likely want to use something that's monophasic rather than triphasic if you're going to do a continuous hormone.
Right, because otherwise you're going like this as opposed to
right. Yeah, there might be right. Yeah.
Right. Yeah. So yeah, go ahead.
No, I was going to say progesterone only pills are always hormone every day. So they're always continuous, but there's much less predictability in periods with that. So you kind of can get a period, maybe not, spotting on or off. So that's why people tend to not use those first line. You typically use those when you really have a person who can't take estrogen, like somebody who has maybe really bad migraine headaches or had a reaction, or if you're breastfeeding, you don't usually take combined contraceptives. So use those.
I guess what we're sort of telling you is that kind of everything has its good and its bad, which you guys kind of knew. We didn't even ask for that.
Right.
But in terms of the low libido, the hormonal birth control, it may not affect you. So you should not go in there thinking, oh my God, I can't use it. But if it does affect you, you can switch. I think Melissa's saying you can switch to different ones because different ones have different reactions.
Right.
There's nothing we can suggest really to counteract that problem. We can possibly fix pain in your vagina as a counteraction, but not really low libido. Is that a sort of fair summary?
I think that's fair. Yes.
Yeah. So
and sometimes you may find, I mean, for some women, like knowing that you're not going to get pregnant can sometimes initially help. But as the years go on, your body changes too. So you may find that like you were fine for the first year, but maybe the second year you're not anymore. So I think we just always need to continue to check in.
Right, exactly. So that's, yeah, okay. So I think that's kind of all we're going to talk about tonight, and I really appreciate it. Next Monday night, Tuesday night, I'm coming on to talk about pelvic pain. I'll be talking about vaginismus, everybody's favorite topic. We'll do another one later on in the season that's like, more complicated pelvic pain, like vulvodynia, vestibulodynia. Although, honestly, Melissa is doing me a favor coming on. This is not her favorite thing. And she's really like, I think she's one of the country experts on vulvodynia and vestibulodynia. So you can always, direct message me if you have a question, or look up May's Women's Health, May's Women's Health. I got that right? Yeah, anyway. And that's where like Melissa is there. Happy to see patients, not so happy to come on social media. So but we really, really appreciate it. And for me, it's just so much fun because I'm just not getting to see you like
I know
times a week anymore like I used to. So so this is like, for me, it's like the next best thing. So I thank everybody for joining us. It was so much fun. I'll be back next week with Jackie, who's another nurse. Oh, you're getting a lot of hearts, Melissa. Everybody loves you.
Oh, that's nice.
Everybody loves you. And have a good night, everybody.
Okay.
Bye-bye.
Bye.